Consider the case of a woman named Margaret. At 68 years old, she remained mentally sharp. Every morning, she completed crossword puzzles. She could recall every family birthday without looking at a calendar. Her daughter often described her as the household's human Google. Then, roughly 18 months after a new prescription was added to her treatment plan, something changed. Her daughter became deeply concerned. Margaret could no longer remember what she had eaten that morning. She sometimes became disoriented while driving home from the same grocery store she had visited weekly for 2 decades. During conversations, she repeated identical questions several times. A neurologist began to suspect the early stages of Alzheimer's disease. The family was heartbroken. However, there was something they had not been told. Margaret's condition was not Alzheimer's disease. The source of her cognitive decline was found inside her collection of medications. After her prescriptions were carefully reviewed and adjusted under physician supervision, her condition began to improve. 4 months later, she had returned to solving crossword puzzles again. This was not a miracle. It was an example of preventable medical harm. The following medications are among the most common drugs that may quietly interfere with memory and cognitive function. It is important to understand one point clearly. No medication should be stopped without consulting a physician. The purpose of this information is to encourage informed discussions and a better understanding of treatments that may affect brain health. The first medication discussed here is diphenhydramine. Many older adults keep a bottle of Benadryl nearby. It is inexpensive, available without a prescription, and commonly marketed as a sleep aid. Yet inside an aging brain, its effects can be far from harmless. Diphenhydramine belongs to a category known as anticholinergic drugs. This term is important because it appears repeatedly when discussing medications linked to memory concerns. Anticholinergics work by blocking acetylcholine, a neurotransmitter that plays a major role in memory formation, concentration, and alertness. Younger individuals generally have a larger reserve of acetylcholine. After age 60, those reserves are already lower. When diphenhydramine further reduces available acetylcholine, the impact can become significant. A major study published in the Journal of the American Geriatric Society reported that older adults who used diphenhydramine regularly experienced a noticeably higher likelihood of cognitive decline. Brain imaging also revealed measurable shrinkage in regions associated with memory. Another concern is that diphenhydramine appears in many products that people do not immediately recognize as antihistamines. Products labeled PM, nighttime relief, or sleep formula frequently contain this ingredient. For allergy treatment, physicians may recommend second-generation antihistamines, such as loratadine, sold as Claritin, or cetirizine, sold as Zyrtec. These medications generally do not cross into the brain in the same manner. The next category is proton pump inhibitors, commonly called PPIs. Many individuals take a reflux medication every morning and continue doing so for years. In many cases, no one ever discusses reducing or discontinuing treatment. This group of medications has become one of the most frequently prescribed categories worldwide. The concern is not simply their use. The concern is long-term use when many of these medications were originally intended for periods of only 8 to 12 weeks. PPIs reduce stomach acid production. While that sounds beneficial for reflux, stomach acid also performs another essential task. It helps separate and absorb vitamin B12 from food. Vitamin B12 is critical for normal brain function. Deficiency has been associated with memory problems, depression, nerve injury, and cognitive decline that can closely resemble early Alzheimer's disease. The similarity can be so strong that even experienced physicians may confuse the two conditions. A study published in 2016 in JAMA Neurology examined more than 73,000 adults aged 75 and older. Researchers found that long-term users of PPIs had a 44% greater risk of developing dementia compared with people who did not use these medications. The concern extends beyond vitamin deficiencies. Research has suggested that PPIs may contribute to increased accumulation of amyloid beta plaques, protein deposits that are considered a hallmark of Alzheimer's disease. This raises the possibility of a more direct biological connection to neurodegeneration. Patients concerned about long-term use may discuss tapering strategies with their physicians. Some doctors use H2 blockers, such as famotidine, sold as Pepcid, as a transitional option. Lifestyle changes may also help reduce reflux symptoms. Smaller meals, avoiding late-night eating, and elevating the head of the bed can sometimes make a meaningful difference. For those who require long-term PPI therapy, regular monitoring of vitamin B12 and magnesium levels may be important. Another medication group involves treatments for bladder control problems. Overactive bladder is a genuine medical condition. It can be disruptive, embarrassing, and damaging to quality of life. When patients receive a prescription for oxybutynin and are told it may help, most naturally follow that recommendation. What many people are not told is that oxybutynin ranks among the most powerful anticholinergic medications commonly prescribed. Its effects are not limited to the bladder. The drug crosses the blood-brain barrier easily and interferes directly with acetylcholine pathways involved in memory and learning. Research has shown that the hippocampus, a region heavily involved in memory processing, can exhibit measurable reductions in volume among long-term anticholinergic users. This is not simply a matter of temporary mental fog. It involves observable structural changes within the brain. A comprehensive study published in the British Medical Journal during 2019 found that seniors who used strong anticholinergic medications such as oxybutynin for longer than 1 year experienced a 49% higher likelihood of receiving a dementia diagnosis. One of the most troubling aspects is that early symptoms are often dismissed as normal aging. Missed appointments, misplaced belongings, or difficulty finding words during conversation may be attributed to getting older rather than to medication effects. As a result, the prescription itself may never be questioned. There is, however, an alternative. Newer bladder medications, such as mirabegron, marketed as Mirbitriq, operate through a different pathway known as beta-3 adrenergic agonism. Because they use a different mechanism, they are associated with substantially lower cognitive risk. Anyone currently taking oxybutynin who has begun noticing changes in memory, focus, or mental clarity should discuss those concerns directly with a urologist or primary care physician. Another major category involves benzodiazepines. This subject often generates strong reactions, and for good reason. Benzodiazepines, often called benzos, have provided relief for millions of people struggling with severe anxiety, panic disorders, and sleep disturbances. For many individuals, these medications felt indispensable during extremely difficult periods of life. That reality should not be ignored. At the same time, scientific evidence deserves careful attention. These medications work by increasing the effect of GABA, a brain chemical that functions as the body's natural calming signal. Their short-term effectiveness is well established. The concern emerges when this mechanism remains active for months or even years. A study published in 2022 followed more than 8,000 seniors over a 6-year period. Researchers reported that individuals using benzodiazepines for longer than 3 months faced a 51% higher risk of Alzheimer's disease. The greatest risk appeared among long-acting formulations such as diazepam. These drugs can accumulate within fatty tissues, including tissue found in the brain. The biological explanation is straightforward. When GABA activity remains continuously amplified, the brain gradually reduces its own natural responsiveness. Neuroplasticity begins to weaken. This is the brain's ability to build new connections, acquire knowledge, and adapt to changing circumstances. Memory formation slows. Emotional control becomes less stable. A brain that was once being soothed gradually loses some of its flexibility and responsiveness. Another problem emerges when discontinuation is attempted. Withdrawal symptoms can be severe. Anxiety and insomnia may return with greater intensity than before treatment began. As a result, the medication can seem essential even while contributing to the underlying issue. Abrupt discontinuation should never occur. Stopping benzodiazepines suddenly may create serious medical risks. Any reduction should take place under physician supervision through a gradual taper that may extend across weeks or months. Possible alternatives include buspirone for anxiety. For sleep-related concerns, cognitive behavioral therapy for insomnia, known as CBTI, may be considered. In some situations, low-dose melatonin or magnesium glycinate may also be used. Next comes statins. This topic requires careful balance because statins unquestionably save lives. Cardiovascular disease remains the leading cause of death among adults older than 60. For many patients, statin therapy is both appropriate and beneficial. However, there is another side of the discussion. The human brain consists of nearly 60% fat. Within the brain, cholesterol serves critical structural functions rather than acting as a simple villain. It contributes to the formation of myelin, the protective coating surrounding nerve fibers that allows signals to travel rapidly and efficiently. It also plays a role in creating synaptic connections. Without sufficient cholesterol, communication between neurons becomes more difficult. When cholesterol levels are lowered aggressively through statin treatment, some researchers believe there is a possibility that the brain may not always receive everything required to maintain normal structure and function. In 2012, the FDA revised statin labeling to include memory loss and confusion among potential side effects. This action followed review of thousands of adverse event reports submitted by patients. A 2023 analysis published in Frontiers in Aging Neuroscience reported that adults over 70 who used high-dose statins continuously for more than 3 years demonstrated measurable increases in mild cognitive impairment compared with non-users. An important detail is that cognitive risk may differ among various statins. Lipophilic statins, including simvastatin and atorvastatin, cross the blood-brain barrier more easily. Hydrophilic statins, such as pravastatin and rosuvastatin, have shown substantially lower effects on cognition in comparative research. Individuals taking statins who experience memory difficulties or persistent brain fog may wish to ask their physician whether switching to a hydrophilic option could provide cardiovascular benefits while reducing cognitive impact. CoQ10 levels may also deserve attention. Statins can reduce this compound, which plays a vital role in cellular energy production within the brain. Another medication of concern is amitriptyline. This drug frequently surprises people because it is often prescribed for conditions that seem unrelated to mental health treatment. It may be used for nerve pain, prevention of chronic migraines, fibromyalgia, or insomnia. Amitriptyline is an older tricyclic antidepressant that has been adapted over the years for many different purposes. Some physicians select it partly because its sedating effects can help patients sleep. The concern for older adults is its exceptionally strong anticholinergic activity. Among medications still widely prescribed today, it ranks among the most potent. Its attraction to muscarinic receptors, where acetylcholine normally performs its functions, is extremely strong. In fact, this affinity exceeds that of many drugs originally designed for bladder disorders or allergy treatment. A landmark study published in 2015 in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older over a 10-year period. Researchers found that high cumulative exposure to anticholinergic medications, with amitriptyline among the leading contributors, was associated with a 54% increase in dementia risk. The findings were not limited to high doses. Even smaller amounts taken consistently over many years created a significant cumulative burden. One challenge is that the harm often develops quietly. There is rarely a dramatic warning. Instead, subtle difficulties emerge. Finding the right words becomes harder. Organizing thoughts becomes more difficult. Maintaining complex mental processes gradually becomes challenging. These changes are often mistaken for ordinary aging long before anyone considers the role of medication. For nerve pain, alternatives such as duloxetine, marketed as Cymbalta or gabapentin, generally carry much lower anticholinergic burden. For sleep problems, very small doses of doxepin may offer a more favorable receptor profile than amitriptyline. For mood-related conditions, modern SSRIs such as sertraline are considered considerably safer for aging brains. The next category is antipsychotic medication. This issue requires close attention because it occurs daily in nursing homes, memory care facilities, and hospitals across the country. Many families never become fully aware of it. Antipsychotics were originally developed to treat serious psychiatric illnesses, including schizophrenia and bipolar disorder accompanied by psychosis. These medications exert powerful effects on the brain and carry significant side effect risks. Today, however, they are frequently prescribed off-label to older adults who are confused, restless, agitated, or difficult to manage. In many situations, the prescription is not driven by psychosis. Instead, it is used because the patient is viewed as difficult to handle. As a result, some seniors living in long-term care settings receive antipsychotic medications primarily to keep them sedated. The FDA issued a black box warning regarding this practice more than a decade ago. The warning cited an increased risk of death among elderly patients with dementia-related behaviors. Despite that warning, prescribing continues. The neurological mechanism is significant. Antipsychotic medications primarily work by suppressing dopamine, a brain chemical involved in motivation, reward processing, movement, and executive functioning. When dopamine activity remains suppressed for long periods in an aging brain, several consequences can emerge. Emotions may become muted. Thinking processes can slow. The ability to store and organize memories may weaken. Neurodegeneration can progress more rapidly. A study published in The Lancet Healthy Longevity in 2022 followed more than 25,000 older adults. The findings showed that seniors who received antipsychotic medications for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even when no previous dementia diagnosis existed. If a family member resides in a care facility, or if medications such as quetiapine or risperidone are being prescribed for reasons other than documented psychosis, important questions should be asked. Ask why the medication was chosen. Ask what strategy exists for discontinuation. Ask which non-pharmaceutical behavioral approaches have already been attempted. Those answers should be available. Next is paroxetine. This medication receives far less attention than it deserves. Paroxetine, sold under the name Paxil, belongs to the SSRI category, meaning selective serotonin reuptake inhibitors. It belongs to the same family as Prozac, Zoloft, and Lexapro. Most people hear the term SSRI and immediately think of a newer antidepressant that is generally safer and easier to tolerate than older drugs. For most medications in this class, that perception is accurate. Paroxetine is different. Unlike the other SSRIs, paroxetine possesses significant anticholinergic properties. That single characteristic sets it apart from the rest of its drug family. While medications such as Zoloft and Lexapro leave acetylcholine largely unaffected, Paxil interferes with that system in a manner more similar to older tricyclic antidepressants. A comprehensive review published in Frontiers in Psychiatry during 2021 found measurable declines in short-term memory and verbal recall among elderly patients taking paroxetine during the first year of treatment. Those changes were not observed among patients using other SSRIs at similar doses. The American Geriatric Society has included paroxetine on the Beers criteria. This official list identifies medications considered potentially inappropriate for older adults because of specific safety concerns, including effects on cognition. One of the most frustrating aspects is that paroxetine is frequently prescribed to older adults for anxiety and depression, the very group facing the greatest risk from its cognitive effects. The potential solution is straightforward. Individuals over 60 taking Paxil may wish to discuss alternatives with their physician. Options such as sertraline, sold as Zoloft, escitalopram, sold as Lexapro, or another SSRI may provide comparable antidepressant benefits while avoiding the anticholinergic burden. With careful tapering, many patients transition successfully. The final concern is not a single medication. It is anticholinergic polypharmacy. This may be the most important issue discussed. Any one medication on this list may produce only subtle cognitive effects when taken alone. Perhaps a little forgetfulness. Perhaps mild brain fog. Perhaps small changes that are easily blamed on aging. Real life, however, rarely involves a single medication. The average American older than 65 takes 4 or more prescription drugs every day. Many individuals take 6, 8, 10, or even more. These regimens often combine prescription medications, over-the-counter products, and supplements. Frequently, several different physicians are involved, and each may not have complete visibility into the other's prescribing decisions. When multiple medications with anticholinergic effects are used together, evidence suggests their impact may do more than simply add up. The effects may multiply. An analysis published in Age and Aging during 2022 tracked more than 280,000 older adults. Researchers found that participants with the highest anticholinergic burden, measured through a validated tool known as the Anticholinergic Cognitive Burden Scale, faced a 120% greater risk of developing dementia over a 10-year period. That represents more than double the usual risk. Many of those individuals had never been warned about the potential cognitive consequences of their medications. Consider a practical example. Imagine a 70-year-old woman named Dorothy. Each night she takes Benadryl PM to help her sleep. She uses oxybutynin for bladder symptoms. Recently, she began taking amitriptyline for nerve pain affecting her feet. Every morning, she also takes an over-the-counter medication for heartburn. 3 of those 4 medications possess anticholinergic properties. Viewed individually, each prescription may appear reasonable and safe according to the clinician who prescribed it. Taken together, however, her anticholinergic burden score could fall within a range associated with significant dementia risk. Yet no physician and no pharmacist may have calculated that combined burden. This situation is not merely theoretical. It reflects the experiences of people like Dorothy, people like Margaret, people who may be neighbors, parents, spouses, or close friends. The medical term is polypharmacy, more specifically, anticholinergic polypharmacy. It may be among the most under-recognized contributors to dementia-like symptoms in today's elderly population. There is also an important point to remember. Medication-induced cognitive decline is often reversible. When excessive medication burden is identified and carefully reduced under proper medical supervision, many patients experience substantial improvement. Mental clarity returns, memory improves, personality traits that seemed lost begin to reappear. The mental haze gradually fades. The brain is not a passive structure. It adapts. It demonstrates resilience. It can recover when conditions allow. A practical plan can begin with 5 actions. Start by creating a complete list of everything being taken. Include prescription medications, over-the-counter products, dietary supplements, sleep aids, and occasional remedies. Do not leave out the PM pain reliever used from time to time or the allergy medication that has been taken for years. Next, review each item using the Anticholinergic Cognitive Burden Scale, often called the ACB scale. This publicly available resource assigns scores based on anticholinergic risk and can be located through a simple online search. Then arrange a medication review with a primary care physician. A patient may simply request an appointment to evaluate anticholinergic burden through a medication review. Many physicians appreciate that level of involvement. Another step is discussing deprescribing. This refers to the supervised and intentional reduction or discontinuation of medications that are no longer necessary or that present unacceptable risks. It has become an established and growing area within geriatric medicine. If concerns are dismissed, seeking a second opinion remains an option. Taking responsibility for personal health is not being difficult. It is being proactive. A geriatric pharmacist can also perform a detailed medication review because that specialty exists specifically for issues like these. Many people continue taking one or more of the medications discussed here. Some may have noticed brain fog. Others may have experienced memory lapses, confusion, or changes in personality without ever considering a connection to medication use. For some, concerns about cognitive side effects may have been dismissed. Yet understanding the possibility of medication-related causes is an important first step. Protecting brain health begins with awareness, careful review, and informed conversations with healthcare professionals. Stay attentive, stay informed, take steps to safeguard cognitive function for the years ahead. Please leave your thoughts about this content in the comments below. Thanks for watching. See you in the next one.